participating in the National Foundation for Ectodermal Dysplasia's topical conference call on dental concerns. My name is Kelly Atchison. I may have failed to mention that earlier, and I serve as the NFED's Director of Family Support and Outreach. I provide support and education to those who are touched by ectodermal dysplasia, so most of you on the call I've probably talked to at some point in your time with the NFED. So it's a pleasure to have you with us tonight. As I mentioned, we are recording this call, and it will be available on YouTube for future reference. And to aid in the success of this learning opportunity, I'm going to mute all lines while Dr. Knobloch is presenting. And so there will be a time for questions at the end of her presentation. So I ask that if a question comes to mind while she's speaking, if you'd write that question down, and then when we open it for questions, you'll have time to ask. Dr. Knobloch is an associate professor at the Ohio State University College of Dentistry, and she earned a bachelor's degree in biology from John Carroll University in 1987. She attended dental school at the Ohio State University, where she completed her DDS in 1991. And after dental school, she completed a graduate prosthodontic residency and master's degree, also at the Ohio State University in 1994. Dr. Knobloch became a faculty member in the Restorative and Prosthetic Dentistry Department in 1995 after 6 months in an implant fellowship. And then her current teaching responsibilities include both predoctoral and graduate clinics, as well as preclinic courses. She currently practices dentistry in the dental faculty practice at Ohio State, where a significant part of her practice involves children and adolescents with conditions such as ectodermal dysplasia, cleft lip palate, and unexplained congenital anodontia. And she's currently a dental provider for the Bureau for Children with Medical Handicaps in the state of Ohio, and works with the orthodontic and pediatric clinics on the management of these patients. She has been invited to speak for numerous organizations, including the American Academy of Oral and Maxillofacial Surgery, meeting on prosthodontic management and timing of implant placement in growing patients. She currently serves as the director of the Treatment Center for Ectodermal Dysplasia Patients at the Ohio State University College of Dentistry. And she is the principal investigator for a clinical research project evaluating small diameter implants in cleft palate patients. We are so
good evening, everyone. It is such a pleasure to have this opportunity to speak with all of the families and patients affected with ectodermal dysplasia. As Kelly said, I have been involved in treating patients with ectodermal dysplasia for many, many years. The very first ectodermal dysplasia patient I treated was when I was a graduate prosthodontics resident, and that was back in 1991, and I've just been hooked ever since. I truly enjoy patients from this population, and it's just so enjoyable to me. Tonight, what I would like to do is I would like to speak with you about the standards of care and dental treatment options that you may encounter throughout your journey to treat dental problems associated with ectodermal dysplasia. I've provided the foundation with a short presentation of photographs that I will reference during this time just to give you a visual image of the treatments as I discuss them. One of the most common things that I encounter when I meet a new family or a family that has had a recent diagnosis is I feel like they're a little overwhelmed with all of the options that I'm explaining to them. So it's helpful sometimes to have a visual aid. So hopefully most of you have had a chance to either print this out or you're at your computer and can reference it as we talk. I've also numbered each slide for reference so that as I go through, we'll be able to you won't get lost and I'll stay with you. Ectodermal dysplasia certainly, as you know, can affect the primary teeth, often referred to as baby teeth. It can affect the adult teeth, and oftentimes both the baby teeth and the adult teeth are affected. These effects can range from teeth being malformed to just to plain being missing. And malformed teeth can range from those being slightly smaller to normal tooth size with spaces between them, and sometimes they can have more severe malformations where the teeth appear kind of pointy, which is described sometimes by your dentist as conical. In many cases, let me go ahead and grab my, I'm moving myself around here, sorry about that. And many times the severity of the missing teeth can exhibit a real broad range. Some patients have just a few missing teeth, whereas other patients have several missing teeth, and sometimes in the most severe cases, all of the teeth are missing. I would like to begin the conference by discussing the various prosthetic options using some pictures. It will be helpful to you in the second portion of the conference to be familiar with the options as I go through them, because what I'd like to do in the second portion of the conference is I would like to talk about the different treatments as you go through the various stages of development, meaning from being a real young patient with a new diagnosis to somebody who's 16 or 17 years old. So what I'd like to do now is I would like to start by referring to slide number 1, and you can see in the lower left of the slide there's a little tooth with a number 1 in it, and I think I'm calling this example number 1. So I'd like to begin with that one. So what I'd like to do now is just kind of start with that. There are some things that we'll begin discussing that will just basically be to improve the cosmetic appearance of the malformed teeth. And there are several options that you can do to improve the overall aesthetics. Some options can provide short-term improvement while the patient's still growing, and some of the other options are more permanent, so they are generally delayed until the completion of dental development. Let me go ahead and change something here. Hold on one second. Sorry about that. Okay. So there's several options that we can do to improve overall aesthetics. Some can provide short-term and some can provide long-term. The first option that I'd like to discuss is simply cosmetic bonding. And cosmetic bonding is simply a tooth-colored filling that's applied directly to the tooth in the dental office. An example of this you can see on slide number 1. And for those of you that haven't had any exposure to these, the tooth-colored fillings come in a paste-like substance, and they come in different colors, and they'll match the other teeth. That paste is applied and it's hardened with a light. So the filling sticks to the tooth by a chemical bond. And to establish a good bond, it does require that the patient sit still for quite a period of time, and they have to cooperate with the dentist to a certain point and keep a really dry environment. So obviously, the more teeth that we're going to be reshaping with this bonding, the longer the patient will have to lie still. Tooth-colored fillings can be done at any age, and they can be done on baby teeth or adult teeth. Pediatric dentists are very good and experienced in the management of young patients, so they're a great resource for a lengthy dental procedure in a young patient. So if you look at the first slide, as I described, you'll see that in the left side we have a patient that has ectodermal dysplasia, and they have some malformed teeth, and they have some big gaps between the teeth. And so what we were able to do throughout growth is if you look at the second picture where it says after, you'll see that we've just simply applied a tooth-colored bonding, and it's something that can be used throughout growth and development and even in the midst of orthodontics so that we can reshape those teeth. So that's the first one we'll discuss. All right. Now we're going to move on to slide number 2. And slide number 2 gives us a second option to improve the shape and the cosmetic appearance of the teeth, and this is called a porcelain veneer. Sometimes your dentist may talk to you about a more long-term solution being a porcelain veneer. So an example of this can be seen on slide number 2. And a veneer is a very conservative way to improve the shape of a malformed tooth, and it can be done with pretty minimal removal of tooth structure. The removal of tooth generally stays in the outer layer of enamel, and like a composite filling, the porcelain veneer also depends on a chemical bond to stick to the tooth. Porcelain veneers are much more costly than tooth-colored fillings because there is a laboratory procedure involved. They generally take 2 appointments to complete. The first involves preparing the tooth, and then the second involves bonding it. Porcelain veneers are generally only done on adult teeth, so this would be something that might be an option a little later to improve the overall shape of a malformed tooth. You can see in the pictures in slide number 2, we have a malformed tooth in the before from the side view, and then you can see in the front we've got the front view and the second before picture, and then you can see in the after shot I have the blue arrows that are showing you the porcelain veneer when everything is finished. Okay, so that takes us through the second picture. Now let's go ahead and move on to slide 3. The third option that I'd like to go through is another option to improve the shape of the tooth, and this is something that many patients with ectodermal dysplasia may end up having to deal with, and this would be a crown. And there are some crowns that are specifically made for baby teeth or a temporary type of situation until an adult tooth is ready for permanent replacement, and this is called a stainless steel crown. You can see in example 3, I just am showing you what a stainless steel crown is. And this is silver in color, so it's obviously not done on front teeth. It's only done on back teeth. It generally does not require the removal of tooth structure. In the case of a front tooth, the crown that would be done on a baby tooth is sometimes referred to by your dentist as a strip crown, and that's basically a clear form of a tooth that the dentist will fill with that tooth-colored bonding material. Okay, so we'll move on now to slide number 4. Slide number 4 is just showing us some other examples of more permanent crowns that are for adult teeth only. These crowns are generally not recommended till the patient's fully grown. A regular crown does require a much more significant removal of tooth structure in comparison to really anything else that we do. Permanent crowns can be made of gold. They can be made of a metal gold substructure with porcelain on top, or all porcelain. So an example of these types can be seen in slide 4. If you note in the first picture, you can see that there's quite a bit of removal of tooth structure necessary to place a crown, and that kind of shows you what the tooth looks like when a lot of the tooth structure has been removed, and that's how much has to be removed for a crown. The middle photograph will show you the crowns as they're returned to the laboratory. So the laboratory returns the crowns in that sense, and then the final picture shows you that same patient you see in the before picture with all of the crowns in place. So what we've talked about so far is really things that can be done to reshape a malformed tooth, and that's going to be something that many people will have to deal with. So what I'd like to do now is go through some of the options and some of the pictures that would involve what you could do to replace missing teeth. So these examples are going to be viewed in our next options, which are going to be slides 6 through 13. Let me go ahead here and make sure that I didn't miss anything as I'm talking. I did skip example 5. Example 5 is an example of a bridge, and a bridge is basically going to be to fill a gap where a tooth is missing. And what it does is it's a crown on the teeth that are on either side of that gap, and then those crowns are bridged together. So that is something that can replace a missing tooth, but they're also only done for small numbers of missing teeth. You can't do a bridge that's really long span and expect to get a lot of long-term success out of it. So what I'd like to do now is move on to slides 6 through 13, and these are going to be options to replace missing teeth. Some of these options can be a little bit more extensive than the ones that we've looked at, as you'll see when we start going through these. So let's go ahead and begin with slide number 6. In the 6th example, you'll see that this is a complete denture or a full denture. And a complete denture is a plastic removable appliance, and it's used to replace both teeth and gum tissue. They have a pink portion that represents the gums, and then obviously the plastic teeth. The denture teeth are available in lots of different sizes, shapes, and colors. And there's actually a company in the United States that manufactures a special denture tooth called a Bambino tooth. And these are denture teeth that actually more accurately resemble a child's tooth or a denture made for a very young person. The only thing with Bambino teeth is they're only available in 2 colors, but standard denture teeth, as the child gets older, are available in lots of different colors. The full denture can be helpful cosmetically throughout the years of growth because it makes contact with the gum tissue. Patients can develop sore spots, and those will need to be relieved, especially as the child grows and develops. So if you see in slide number 6, this is an ectodermal dysplasia patient with 1 tooth. You can see I have the arrow pointing at the tooth in the before. And if you look at the after, those are our dentures made, and you can see that a little hole's been made in our denture to allow that little tooth to come through. Okay? So let's move on now to slide number 7. Slide number 7 is going to give us an example of an overdenture. Frequently, patients will come in and they'll ask about an overdenture. So an overdenture is basically a full denture, as we just described previously, but it sits on all of the existing teeth. So it looks just like a regular denture on the outside where the teeth are, but the inside is made to fit over the existing teeth. This type of denture can definitely be helpful to replace missing teeth where the existing teeth are quite small, where they're malformed, or where they're broken down. In general, it's recommended to keep existing teeth as long as possible to prevent deterioration of the jawbone over the years. So this denture does allow us to do that for maintaining the jawbone structure and still address the cosmetic needs of the patient. This type of denture does need space to be made, though, so you really do have to have sufficient space between the upper and lower jaw to do this. If sufficient space isn't there, sometimes it can be difficult, and you can only do one arch or the other, in other words, the upper jaw or the lower. This can definitely be helpful throughout the years of growth, and you can see in the picture I have here, you can see that we've done an overdenture for a patient. A more extensive overdenture treatment can be viewed in the next slide, which would be slide 8. And this is a patient with this is a 13-year-old with a pretty severe malalignment of her jaws. And you can see that the first picture, which is before, is how she looks. And then the middle picture is the dentures in place. And then the third picture is actually her smiling with the dentures in place. So that smile on the right is actually an overdenture that was made on those existing teeth, which you see in the before picture. Okay? So let's move on now to slide 9. And slide 9 is going to be an example of a temporary partial denture. And this is a plastic appliance that's used to replace missing teeth in situations where lots of teeth are missing, but not all of them. So like a complete denture, it's made of a plastic material, a pink plastic, and some tooth-colored denture teeth. This prosthesis does not fit over the teeth, but instead it fits around the existing teeth. If you can see in the picture I have here, the before shows you this patient with 3 teeth, and the middle shows us the temporary partial out of the patient's mouth, and you can see I have some wires in the areas where the teeth are, and those wires go around and they kind of hug the teeth and help the partial stay in place. And then the teeth that are missing are in the spaces where we would need to put them. Okay? And this can definitely be helpful throughout years of growth because it does make contact with the gum tissue. Patients do develop sore spots and they need to be relieved. And we're going to talk about growth in our next section. I'm sure many of you are thinking questions like that right now. So let's go ahead and move on to slide 10, and we're just about through the first part of the presentation. Slide number 10. Oops, hold on one second here. Okay. All right. Okay, don't want to lose my place here. Sorry about that. Okay. The next 3 options to replace missing teeth are going to be starting with slide 10. And these this is actually a removable partial denture, but it is actually a removable partial denture that's done not until the patient's fully grown. So you might hear your dentist talk about a temporary partial or a slipper, and that's what we just looked at in example 9. This example, you can see that there's metal on the roof of the mouth, and so this is actually a metal-based partial, and this is not done until the patient's fully grown. It's very rigid, and it's a very sturdy metal base, and it does have pink gum tissue where they need to be, and then the missing teeth are replaced with denture teeth. It's most often recommended when there's a lot of teeth missing and there's large spaces or gaps to fill. And like I said, it's different from the previous one, where the previous one had a plastic base. This one has a metal base. The next 3 options we'll go through. We'll go to slide 11. This is going to involve the replacement of missing teeth that will require some dental implants to be placed prior to the teeth being made. For those of you that haven't seen dental implants, you can see in the first slide, or the first picture from slide 11, you can see the implants exposed right through the gum tissue there, and they have a little ball-shaped portion on the top where the denture kind of clips into place. So that's actually what a dental implant would look like coming through the gum tissue. These are titanium posts. They're placed in the jawbone, and they're used to help that prosthesis stay in place. The nice thing also about the dental implant is that it does help maintain bone levels, and that will help to prevent some long-term deterioration of the jawbone. The dental implant is placed by a surgeon, generally an oral surgeon or a periodontist. It's placed in the bone, and it's left undisturbed for a period of time before the teeth are made. So sometimes people think they have an implant placed and they leave with the tooth, but that's generally not happened. Generally, the standard healing time for the lower jaw is about 3 months, and for the upper jaw is about 5 months. And although those healing times can be somewhat shorter today as our dental implant technology develops, that's still our standard healing time. Recommended times can vary for the individual's clinical situation as well, and your surgeon is usually your best resource for that. So let's go ahead and I'm going to go ahead here and have you look at slide number 11 in a little more detail. Example 11 is a removable denture that's held in place with the help of those dental implants, and this is called an implant-supported overdenture. In the lower jaw, a minimum of 2 implants is used. However, if we go to the upper jaw, sometimes you would need a minimum of 4. And this type of denture is removable by the patient. It does rest on the gum tissue, so patients can't get sore spots, and it does make contact with the gum tissue also. So you can see the 2 posts coming, the 2 implant anchors that are coming through the gum tissue. You can see the inside of the denture in the middle picture, and then the denture in place viewed from the top in the final picture. Okay? So we're going to go ahead and move on now to slide 11. Example 11 is what we call a fixed implant denture. This is an example showing you one in the lower jaw, and this is not removable. This is fixed into the mouth with small screws, and it can only be removed by your dentist. Sometimes your dentist may call this a hybrid denture. So this type of denture has a metal substructure, and it has pink plastic and tooth-colored denture teeth that are screwed into the implants. You can see in the first picture, which is a view from the top, that the denture has little screws that hold the denture in place. The nice part about this is it has the benefit of not contacting the gum tissue or the ridges. Therefore, you never get sore spots, and pressure spots are not a problem. They're encountered by the patient. If you look at the second picture of the view from the front of a lower hybrid denture, everyone always has the same reaction when they see that and say, oh, my goodness, how does that look when you have that big space underneath the denture? But this is something that you cannot see when the patient smiles. They have to really pull their lip down to see this. So patients generally really like this type of prosthesis. Some patients also ask about food getting stuck under that. Most patients quickly learn to maneuver the food while eating to prevent this problem. And another option, which I don't have shown here, is a hybrid for the upper jaw. And sometimes you might hear that described also as an all-on-4. But essentially, whether it's for the lower or the upper jaw, the standard look is going to be the same. You're going to have a little space underneath it to clean, and the reason for that is that you can't take it out. So you as a patient need to be able to get underneath that to floss and to brush and keep that clean. We're going to now move to example 13, and this is our last example, and then we're going to talk about applying some of these examples to patient treatment as they go through the years. So slide 13 is going to show you an example of crowns that are supported by dental implants. So the first picture is a picture before treatment. The second picture shows the implants in place, and the third picture shows the crowns on the implants. These are crowns that, again, are fixed in the patient's mouth, and they're not removable. Generally, we rely on one implant to support one tooth. However, there are some areas where implants can be bridged together, making fewer implants necessary. In the case where a full crown will be placed on a dental implant, the component that is attached to is called an abutment, and implant crowns can be either screwed into place, and sometimes they're cemented into place. So I think the bottom line is that they're placed by the dentist and cannot be removed by the patient. And they can be made, again, of gold, metal gold substructures to porcelain, or all porcelain. So now we've gone through all of the examples that would probably be pretty standard in what your dentist may be discussing with you. So what I'd like to do now is use our foundation so we can speak about the different prosthetic treatments and incorporate those into the various ages and dental developmental stages that will occur. Probably the most common question that I receive from both patients and their families is, how old do I have to be to have my teeth replaced? And this is always a really complicated question that requires explanation. So to help address this issue, what I'd like to do now is discuss the treatment options in conjunction with the various dental stages that you'll go through. And in addition, we'll outline the dental standards of care that we actually consider at each stage. So the first stage I'd like to go through is the time when only baby teeth are present. And this is generally from approximately 1 to 5 years of age. So in a patient with ectodermal dysplasia, I find this to be a really stressful time for the family, most often because sometimes they're just discovering the fact that the child has missing teeth, and they're just beginning to gather information about short-term and long-term dental care. So this is always, I think it's always an appointment that we try to really take a lot of time with because there's always a lot of questions to be answered. If the child has the majority of their baby teeth, then routine cleanings and exams are really important. If the child is missing several baby teeth, then dentures can and should be considered during this time. There's a couple considerations to discuss, though, with regard to dentures in a young child. If you think back to that very first example I gave you of a denture, you can probably imagine that it doesn't look like it's too easy to wear. So the first thought is exactly that, and that's the dentures are difficult to wear. Even the best dentures in an ideal mouth are difficult. And I deal with a lot of adult patients, too, that don't have ectodermal dysplasia, and I know how difficult dentures can be for them. So when you're dealing with a child, it doesn't get any easier. Sometimes kids are a little more resilient than adults, though. So just kind of always remember that even the best-made denture in an ideal mouth can be difficult. The other thing to consider is that when there are no teeth developing, which is often the case with ectodermal dysplasia, the ridge to support those dentures is also deficient, making the support for the dentures definitely less than ideal. So because the dentures are difficult to wear, it does require patience and incredible persistence from the parents to help the child go through that adjustment period required for dentures. The other consideration, and I've actually seen this throughout the years, is that the earlier a patient gets used to wearing a denture, the easier it can be as they age, simply because they just get used to wearing a prosthesis. The older a child gets, they kind of figure out how to eat without a denture, and their friends get used to their appearance, and sometimes their motivation to go through that very difficult adjustment period with dentures can be diminished. Ideally, though, the child does need to be motivated to wear the teeth and does need to express a desire to have teeth, or the chances of success are limited. And this motivation can come from various sources. It can come from family. It can come from peers. It can come just from the standpoint that they would like to be able to chew better. But definitely, there's got to be some motivation there. But if they wear them at a younger age, they definitely can. They seem to adjust as they get older a little bit better. So that was the first stage we just went through was between ages 1 and 5. What I'd like to do now is go through the next stage, which your dentist may call the mixed dentition stage. And this is a time when your child may have a mixture of baby teeth and adult teeth. It's usually from about 6 to 13 years of age. Now, in a patient with ectodermal dysplasia, there may be a limited number of adult teeth forming. Therefore, they still may have lots of baby teeth in place, and they'll hold on to those baby teeth, indefinitely into the late adolescent years for sure. If an adult tooth is missing, the baby teeth generally won't fall out, because what makes baby teeth fall out is that the adult tooth resorbs the root, or it kind of eats away at the root, and eventually that's all that you have left is the little crown that you see in the mouth from the baby tooth, and it eventually just falls out. So again, you have to have an adult tooth erupting to resorb away the roots to make the baby teeth fall out. So if there aren't adult teeth, you'll hold on to baby teeth for a long, long time. One of the most important issues to remember during this time is that in the absence of adult teeth, that child could hold their baby teeth for a long time. And it's really important that these baby teeth are not extracted. And that's because they are serving a purpose. They're maintaining the bone for supporting future prosthetic treatment, whatever it may be. So as the child continues to grow, the baby teeth may start to look a little small in appearance. So in addition, any of the adult teeth that are present may be malformed or small in size. So cosmetic improvement can be done during this stage with tooth-colored fillings known as bonding. We talked about that in our very first example. And remember that cosmetic bonding can be done over and over again, and it can be done to enhance the size and shape of the teeth during that time. So again, these can be done in both baby teeth or adult teeth. So if the child has spaces where teeth are missing, these spaces can be filled in with a removable prosthesis, such as that temporary partial. And families will often ask me if wearing that prosthesis will somehow affect their growth. Will it somehow negatively impact their growth? And the answer to this is no. And what actually happens, and this is what we have documented in our literature, and this is what I see in my practice, is that what actually happens is as the child grows with that temporary partial in place and as the jaws enlarge, the prosthesis actually becomes displaced or kind of pushed out of the way, so to speak. So that removable prosthesis will all of a sudden begin to maybe not fit as well, or the child may start to develop some sore areas known as pressure spots that have to be adjusted. And these can be easily adjusted as needed. They can be relined if we need to, and then they have to be remade if the mouth changes are significant. In general, replacing those missing teeth with a permanent prosthesis or implants is not recommended until growth is complete. There is one exception to that rule, and that occurs during this time frame that we're discussing right now, which is ages 6 to 13, or what we call sometimes the mixed dentition stage. In general, the only place in the mouth where dental implants can be placed at an early age, prior to the completion of growth, is the front of the lower jaw. And it can only be done under the circumstances where there are no baby teeth present and no adult teeth forming. The reason that this can be done is that when you don't have teeth present there, you're not going to get any growth of the jaw. The jaw is not going to get any taller, and the widening of the jaw in that particular area in the front of the lower jaw is complete by about age 6. So our standard of care in this situation is to place 2 implants in the front anterior area of the lower jaw, and then those 2 implants will help us hold that lower denture in place In addition, the placement of these implants will also help maintain jawbone in the long run for future prosthetics. Remember that we discussed an example of this earlier in the talk where we showed you the denture that was anchored by the two implants in front. So the first two stages that we have discussed kind of pertain to the patient who's still actively growing. Okay, so that's the first stage being from birth to 5, and the second stage being from 6 to 13. And obviously, in those time periods, this patient's still quite actively growing. So these are some standards of care that we have developed at The Ohio State University for a patient who is still growing. The first one is to restore with complete dentures, or to actually make complete dentures for a patient who does not have any teeth or is missing most of their teeth. So early restoration with a complete denture is one of our first standards. Keeping the baby teeth as long as possible to help keep the bone from deteriorating. Again, something that we really try to do if at all possible. We keep the adult teeth whenever possible, even if they're malformed or in a bad position, because they will help to maintain the bone. If the teeth are in a bad position, we'll consider orthodontics. If they're malformed, we'll go ahead and reshape them, at least temporarily. And we'll use tooth-colored fillings to improve the cosmetics of baby teeth or adult teeth if needed. At this age, we'll usually get a consultation with an orthodontist, but we won't do that until any adult teeth that are developing are present, and those can be used to assist in the correction of malpositioned teeth. We place implants in the lower front jaw in a patient who's 6, who's missing all of their baby teeth and adult teeth, and that will help to hold and stabilize that lower denture in place. We replace missing teeth with removable temporary partials throughout growth, and we continue to assess growth to determine the timing of any final prosthetic treatment. So those are our standards that we use at Ohio State for those first two stages when the patient's definitely going through some pretty active growth. The third stage is the final stage, and this generally occurs during the time frame from the ages 13 and up. During this time, obviously the patient is still growing, but we start to kind of look more towards our long-term replacement of teeth at this time. And during this time, baby teeth that do not have an adult tooth to replace them are still often present. In addition, any adult teeth that are present may be positioned poorly due to spaces left by missing teeth. So this is the time when we can start to really initiate orthodontics if needed. This is also a time frame when we start to assess the patient's growth to plan for their final replacement of teeth or their final prosthetic treatment. In general, chronological age, meaning how old the patient is not used to establish the completion of growth. One of the most common questions that I get is, how old does my child have to be to have their implants placed? And we don't use an age as an example. We use skeletal maturation or the completion of growth. From a chronological perspective, we do know that girls tend to reach puberty and develop about 2 years earlier than boys. Some girls may be fully grown by ages 15 or 16, where boys may continue to grow into their 20s. So the completion of growth is established with the help of some x-rays. And the most common technique that we use is an x-ray of the side view of the head. This is sometimes called a lateral ceph x-ray. This x-ray uses the shape of the vertebrae in the neck, and that helps us to establish what stage that child's at with regards to growth. Another common x-ray is the hand-wrist x-ray, and this x-ray looks at the development of the bones in the hand and the wrist to determine the completion of growth. It's definitely best to be conservative when establishing that point of skeletal maturation, and always remember it's in your best interest to delay the placement of implants until growth is complete. If implants are placed before growth is complete, then the end result can definitely be impacted from a cosmetic and a functional perspective, except for that area in the lower anterior jaw and that very unique situation that we talked about. Remember that you're going to have many, many years to live with the final prosthetic replacement of your teeth, so any necessary delays to really assure that your growth is complete will pay off in the long run. Once growth is complete and all of the teeth that are present are aligned, then you're at a point where you can begin to extract your baby teeth and replace those missing baby teeth with temporary partials. And then at that time, you can begin to implement your final prosthetic plan. The final prosthetic plan will run a huge range because every patient's situation is different. It could involve cosmetic bonding, crowns, or veneers to improve the shape of the teeth. Many times crowns are necessary to improve the bite. And then implant crowns or dentures can be used to replace missing teeth. And many, many patients have a combination of all of those options that I showed you pictures of to actually get them to that final point. Communication between all of the dental professionals is very, very important to really ensure, continuity of care and give you the best possible outcome. So this is a list of some standards that we have developed at our treatment center for a patient who is finished growing. These are some standards that we use for patients with ectodermal dysplasia. We assess the growth at first to confirm that the patient is skeletally mature and it's okay to begin treatment. We remove baby teeth at the completion of growth and when you have a final prosthetic plan in place. We hold on to adult teeth when at all functional. We will use orthodontics to reposition those adult teeth if necessary. And the determination of the final prosthetic plan will be the very last thing that we do. At that point, the prosthetic plan has been in place as we go through any type of orthodontics or any type of treatment in this stage. But it isn't until all of those things are done that we actually can begin to kind of take that plan to fruition. Usually we will try to place implants if applicable, if teeth are missing at the completion of growth. We will, use their tooth color fillings, veneers, or crowns to improve cosmetics and function. And then our whole overall mission is the rehabilitation of function and cosmetics, regardless of what prosthesis is selected. And prostheses can be permanent partials. They can be implant crowns. They can be dentures or overdentures. So whatever we pick, our mission is the overall rehabilitation of function. In closing, I'd like to really thank all of the wonderful patients that have entrusted their care into my hands over the years. Each time I meet a new patient, I'm just humbled to see, or even see a returning existing patient. I'm humbled at their resilience, their resistance to let this rule their life, and really their ability just to cope, which is often a very difficult dental situation. I can honestly tell you that I truly enjoy working with patients with ectodermal dysplasia. I can honestly say that I'm a better dentist and a better person as a result of my professional interaction with these patients in my practice and in my teaching. And I really want to thank the Foundation for all of their support over the years. They provided me with tremendous support, and I'm so grateful for this opportunity to interact with your patients this evening. And I would certainly be happy to address any questions at this time.
Well, thank you, Dr. Knobloch. We certainly appreciate your time.